Welcome to New Horizons in Pediatric Dermatology Disease. I'm Dr. Adelaide Hebert. I serve as Chief of Pediatric Dermatology at the McGovern Medical School in Houston, Texas. Today we will discuss atopic dermatitis in terms of current advances. We will also look at the advances in terms of influencing patient care and the current guidelines of care for atopic dermatitis. We recognize that greater understanding of the pathophysiology will help us with using the emerging therapies to the greatest advantage in patient care. Here are the guidelines from the United States. Note that the use of moisturization is recommended across the full scope of atopic dermatitis disease. If we look at the European Task Force in atopic dermatitis, we also see that the cornerstone of therapy is using a moisturizer daily, irrespective if your atopic dermatitis is mild, moderate, or severe in nature. As we go on looking at the pathophysiology of atopic dermatitis, we see the many influences: the barrier defect, genetic predisposition, the environment, and so forth. Indeed, if we see, as depicted here in this patient, the barrier defect is really a cornerstone and an initiator of the pathogenesis of atopic dermatitis. We recognize that the skin barrier really manifests as an increase in transepidermal water loss and, unfortunately, the increased penetration of allergens and infectious agents that act as triggers for this disease state. These contribute both to inflammation as well as pruritus. We recognize that the classic concept of atopic dermatitis talks about the trinity of the barrier defect, allergy, and pruritus. We also know that this interplay results in influence of upregulation of inflammatory cytokines and further destruction of the barrier itself. We also know that inflammation can be acute, subacute, and chronic. We see increased pro-inflammatory cytokines in atopic dermatitis, which include tumor necrosis factor, interleukins such as IL-4, IL-9, and IL-22. We have many other cells, including plasma cells, mast cells, eosinophils, B and T lymphocytes, which play key roles in this inflammatory process. So we look at the role of oxidative stress as a new construct with regard to various disease states in the realm of medicine. We have long known that we can implicate oxidative stress in cardiovascular disease, diabetes, neurodegenerative inflammatory diseases, as well as cancer. Oxidative stress in atopic dermatitis is a more recent concept which has been recognized. We know that oxidative stress plays a key role in worsening the barrier defect in atopic dermatitis. Therefore, we really want to focus in the future on means to reduce this oxidative stress and repair that barrier disorder. We are able to do this by recognition of the oxidative stress as really being an important factor in the pathogenesis of atopic dermatitis. Why is oxidative stress important? Well, there is damage to cellular structures, there is resultant inflammation, and again, defects in the skin barrier which warrant repair. We know that oxidative stress in atopic dermatitis has really been in the medical literature for at least 28 years, but has really come to the forefront more recently as we better understood the pathogenesis of this disease state overall. We also know that oxidative stress promotes tissue inflammation because there is upregulation of inflammatory cytokines. These inflammatory cytokines release free radicals. So oxidative stress thus plays a key role in atopic dermatitis. We also know that oxidative stress can actually be due to factors such as environmental issues, physical, emotional, psychological issues as well. Now, air pollutants, tobacco smoke, volatile organic compounds, formaldehyde, and other agents may also relate to oxidative stress within the realm of atopic dermatitis. We recognize the role of oxidative stress in activating NF-kappa beta pathways, which lead to gene expression and synthesis of antioxidant enzymes in the skin. This resultingly can cause direct damage to epidermal keratinocytes by DNA damage, damage to cellular enzymes, and damage to cell membrane structures through lipid oxidation. Thus, we really want to recognize the important factors implicated in the pathogenesis and outcomes related to atopic dermatitis. And I've listed these for you here, including environmental as well as other factors which play key roles. Now, we have come to recognize an important scientific rationale to actually use an emollient device enriched with antioxidants when one is caring for a patient with atopic dermatitis. This particular publication really cites a unique agent which contains furfuryl palmitate as part of the emollient device. Again, furfuryl palmitate in an emollient has been cited in this particular article, looking at the therapeutic benefits and enhancing the permeability barrier for those suffering with atopic dermatitis. We also recognize that emollients with antioxidants really do have a scientific basis in improving the skin barrier, and this guide, published in the Asian literature, references exactly the use of new agents such as those containing vitamins and furfuryl palmitate in the improvement of the barrier by use of emollient devices enriched with antioxidants. We know that these are innovative processes in the overall strategy in managing atopic dermatitis. These emollient devices, particularly those with antioxidants such as furfuryl palmitate, really do have an impact in reducing inflammation and effectively restoring the skin barrier. Recently, I have also published in the International Journal of Women's Derm how oxidative stress really must be focused on as a treatment target in managing atopic dermatitis fully and effectively. And I also cite the use of furfuryl palmitate in the emollient devices to treat mild to moderate atopic dermatitis. Now, we know that oxidative stress plays a key role in the etiology of atopic dermatitis. So addressing it and treating it effectively really become paramount as part of our therapeutic strategy. We also recognize that if we use these targeted therapies, such as emollient devices containing furfuryl palmitate, we can really restore the barrier and favorably impact the overall outcome of atopic dermatitis management. We've also looked at other targeted treatments, including furfuryl palmitate or its derivatives, which can be effective in using agents such as emollient-based targeted agents to reduce the need for steroids, particularly topical steroids, when managing atopic dermatitis. So, in summary, what we really recognize is that topical antioxidants can be used very effectively in managing atopic dermatitis. These targeted agents, such as furfuryl palmitate containing emollient devices, really can benefit our patients overwhelmingly as we manage their disease state. So in conclusion, while we recognize that atopic dermatitis remains a challenging condition both to understand as well as to manage, if we recognize the role that oxidative stress plays in managing atopic dermatitis, we can find new agents for barrier repair. There is a new generation of prescription emollient devices that are enriched with agents such as furfuryl palmitate, a topical antioxidant, which can truly reduce oxidative stress in those patients suffering with atopic dermatitis. We want to look next at new therapeutic horizons in the management of diaper dermatitis. We recognize that diaper dermatitis, which is also called diaper rash or nappy dermatitis, is one of the most common disorders that we see of the skin involving both infants and toddlers, those who wear diapers. There have been several technological advances recently in both diaper design and other components that lessen the severity of the diaper dermatitis findings. However, due to the unique environment of wearing a diaper, children and adults who wear diapers continue to have a current challenge related to diaper dermatitis occurrence. We recognize the four main pathophysiologic components in developing diaper dermatitis. Of course, we have irritation, a natural skin barrier defect because of the diaper, we have inflammation, and microbial contamination. What we want to think about in terms of benefiting those patients suffering with atopic dermatitis is a barrier cream, such as found in zinc oxide, a repair cream, such as one with dexpenthanol. We also want to think about anti-inflammatory properties, such as taurine, and the antimicrobial properties provided by zinc gluconate. There can be some very important clinically evidence-based paradigms using certain formulations, particularly those that contain both zinc oxide, dexpethidine, taurine, zinc gluconate, almond oil, and these are all found in the Relizima baby care and the Relizima spray and go. These have been effectively evaluated and shown to have good dermoprotective efficacy. They can reduce the erythema, and they have good cosmetic acceptability. We actually have clinical studies on infants aged 3 to 36 months with Fitzpatrick skin types ranging from 1 to 4. There was some slight irritation in the diaper area as determined by board-certified dermatologists and pediatricians where this product was considered clinically effective. We look at this evidence-based paradigm and we see both Relizima baby care and Relizima spray that can effectively reduce the erythema in the toddlers and infants who suffer with diaper dermatitis after just 2 weeks of application. We also recognize those 4 main pathophysiologic mechanisms that cause diaper dermatitis, including irritation, the skin barrier defect, inflammation, and the microbial contamination. Based on clinical studies in pediatric patients aged 3 to 36 months, we know that the novel combination containing zinc oxide, dexpanthenol, taurine, and zinc gluconate have shown to be both effective and safe add-ons for treating and preventing diaper dermatitis. Thank you.